Able to On Air is generously supported by Green Mountain Support Services to empower neighbors with disabilities to be home in the community. Other sponsorship include Washington County Mental Health, where hope and support come together. Hello and welcome to this edition of Able to On Air, the one and only program that focuses on the needs, concerns, and achievements of the differently able. I've always been your host, Lawrence Seiler. Arlene is off today. Thank you to our wonderful sponsors, especially Washington County Mental Health and Green Mountain Support Services. With us to discuss this important topic of nursing and people with special needs. What if you are a person with a special need and need extra nursing care? Where do we turn? With us to discuss that is Green Mountain Support Services. Why don't you guys introduce yourselves?
Great. Hi, my name is Christina Bell, and I'm a registered nurse at Green Mountain Support Services. I primarily work with individuals with developmental disabilities. I also work with Tanner in the traumatic brain injury and adult family care programs. I've been at the agency for about a little over 2 years now.
And you are?
Yep, and I'm Tanner Kadleck, also a registered nurse, and as Christina said, I work primarily with the adult family care program, so older adults needing more assistance to live in their communities, and individuals with traumatic brain injuries.
So what is the missions and goals of Green Mountain Support Services and the nursing program?
So our, I guess, our company focus is empowering neighbors to with disabilities to be at home in their community. Mm-hmm. And so basically what this means is that as people progress through life and they need more and more services, it's our focus to keep people in a position where they can really have a say on what's going on in their life and really experience everything they want to and not have to rely on institutional support.
Mm-hmm. When you say rely on institutional support, take me back. I know years ago there were, especially in Vermont, Brandon State School and other institutions. How has nursing changed over those years and going into now?
Would you like to?
Yeah, I think so. First off, I just wanted to reiterate that
if we make a mistake, we can always go back.
Yeah, that's fine. So us as nurses, I feel as though our primary mission is to support the health and wellness of all of the clients that we serve through Green Mountain Support Services, whether they have developmental disabilities or, you know, they're elderly and they have some sort of disability, and our primary focus is to keep them in the home. And that's how it had been in the past with a lot of institutions that, you know, they would have group homes or they would have just a designated institution like the Branded Training School where individuals were sort of grouped together. Mm-hmm. And it was sort of this, you know, they were all grouped together and together they would just be there in this one area, and they were not, it was not reflected at so much as, you know, you're in your home, you're in your comfortable environment. It was more of sort of, you know, you have all these strange faces around in this, you know, big building, and so we're mostly trying to keep people in their homes where they're comfortable, mm-hmm. where they can sort of, you know, have that autonomy to be themselves.
When we say being independent and being on our own, mm-hmm. when you're dealing with nursing care, what exactly does that mean and how does that work?
Take that one, Dana.
As far as being independent, we want to give people as many opportunities as they can to do everything that they can within their ability. And then we
From
are...
ADL skills on down, right?
ADL skills, even to where we come in is kind of more nursing-centered skills. We just want to make sure that all the support is there for that person to be as independent as possible.
Describe support in this case.
So, for example, if outside of ADL, say that there is more of a nursing type procedure, like the first example that's popping to mind is, say someone has a catheter. That's something that is going to require an extra level of skill that most people that are providing just basic services aren't going to have. So that's where we come in, and we can coordinate with the physician that's prescribing this catheter or any other device.
For those that don't know, what is a catheter and certain devices that are used? In
so yeah, for example, a catheter would aid in people being able to fully drain their bladders.
Go to the restroom, yeah.
Yeah, and so, and that just requires a certain skill set, and that's our job to step in and make sure that the people supporting our client are educated and able to perform that procedure, or not procedure, but help them with those skills and do so properly and safely.
Okay, since you guys work with developmental disabilities and you're developmental disability nurses, is there, besides nursing school, because you're an RN, right? Mm-hmm. Besides nursing school, is there any other specific training that you go through being and working with people with developmental disabilities? Mm-hmm. Or, you know, in this case, it might be dual diagnosed. So can you explain some of that?
Yeah, so Green Mountain Support Services has a lot of different training opportunities, not just for nurses, but right across the board for everyone. We have a class that we take called Therapeutic Options with our great staff, Marilyn Carter, who teaches that, and she basically talks about approaches to use with individuals with developmental disabilities. It might be a therapeutic communication technique, it might be communication strategies, just to sort of make the person that does not have as much experience working with someone with developmental disabilities a little easier. Just things that, you know, we've all picked up on in the past, things of that nature. I've also been offered through the agency to do a death doula certificate course through the University of Vermont. So
say that again?
It's called a death doula course.
What exactly is that?
So that actually helps support the person who is in the middle of end-of-life care, just helps them and supports them with that process and working with them to sort of make that process easier. And
it's called death doula.
Death doula. So doula is a Greek word. It basically means, I think it's helper or something along those lines. Mm-hmm. So it basically assists someone in their end-of-life dying process.
Since you said that, what is your opinion, being a nurse, mm-hmm. Just an opinion question, mm-hmm. on, you know, there are certain, now I know we're dealing with the opioid crisis and everything, but there are certain drugs such as fentanyl dealing with end-of-life and cancer and certain challenges that mm-hmm. people might have. Mm-hmm. And euthanasia and all of that stuff. Mm-hmm. There's a history with that. Being a nurse, what is your opinion on the death doula end-of-life situation mm-hmm. and those drugs and that type of thing?
Mm-hmm. I think it really depends on the situation and the person and the sort of their own opinion. Mm-hmm. My opinion is it's whatever is right and best for that person at that given time, mm-hmm. because every situation is going to be different. Every pain and comfort level is going to be different. And there's a lot of stigma out there about, you know, pain relief and using those types of heavy euthanasia, you know, sort of pain relieving medications. Mm-hmm. As far as euthanasia goes and actually going through that process, I've actually worked in the past at a home health agency, mm-hmm. and we actually had a patient that was going through that process, and it was what they had, you know, wanted at the time, mm-hmm. and they felt that that was best for them. They weren't going to get better. Mm-hmm. As nurses, we're not actually, it's out of our scope of practice to participate in that. With a hands-on approach. Mm-hmm. We sort of are overseers of care, but we can't really step in and help with that particular process. Mm-hmm. But we can support the patient and make sure that they know we're there to support them. And if they need to talk, if they need, some sort of intervention, whether it be a heating pad or, just sitting with them and listening to
If they're in
calming
hospice,
music.
they want a great meal.
Exactly.
That type of
If they
thing.
want to eat candy, chocolate, cakes, cupcakes, whatever.
Lobster, whatever.
Lobster, whatever they want. We're there to help them, and talk about the dying process and what things to expect. And so yeah, we do get involved with all of that. It's just
Tanner, do you want to take the same question?
Yeah, and I think it comes down to the core of nursing is our real role is to advocate for either our patient or our client, but to be able to do that, we need to make sure that everyone is educated as to all their options as best as we understand them.
Okay. Ethics, very important. HIPAA, certain types of ethics. What, in terms of your field in developmental disabilities, what can a nurse do and what can't you do? And the overstepping of, like, I'll give an example. If, can you have a relationship with the patient in terms of, dealing with family and that type of thing? How does that work within ethics?
It's kind of a tricky question. One, because the nursing field is really, really diverse, and there's so many different avenues that you can pursue as far as where you take care of clients. As far as our setting, we kind of have to get to know our clients and really be part of, or not necessarily be part of, but be aware of their everyday life and know their interests so that we can advocate for them for the things that they are wanting to have happen. You mentioned HIPAA. That gets kind of tricky because when you are out in the community, you have to be careful about
what you say,
and this is especially true for our service providers or people that are with the patient day to day. They can't go to a restaurant and say, oh shoot, I forgot your lactulose, you're not going to be able to have anything dairy. And it's just just simple things like that you might have in a day-to-day conversation with anyone in your family. It's it can be very easy to forget that this is still a client whose privacy that you have an obligation to protect. And so
abuse and nursing, nursing homes, hospitals, etc. You told me off camera that Vermont is strict on that. How strict? How has laws changed regarding that? This question goes to both of you guys. How strict has that been, etc.?
So Vermont is a very, very high advocate for particularly elderly and our younger populations.
People with special needs, yeah.
Absolutely, and all individuals with disabilities. So basically, not just us as healthcare providers are what is called a mandated reporter, which is someone that...
Explain what that is.
Yep, so it's someone that must report if they suspect any kind of abuse, whether it be bruising or things of that nature. Someone says something that they were, maybe they were pushed or they fall down or something happens and there's maybe a little bit suspicion of abuse. They are mandated to report that to the state of Vermont. So basically that doesn't just encompass Tanner and myself as nurses, it also encompasses the service coordinators that we actually work hand in hand with at the agency.
What does a service coordinator do within your nursing situation?
So we actually work with service coordinators quite frequently in the field. They have about 15 maybe to 17 clients on their caseloads, depending on how that fluctuates. Basically, they have a client that they specialize in work with, and then we coordinate with them any sort of if they have any sort of special needs, any care that they might need, we coordinate that through the service coordinator.
So is the service coordinator, does it act like an interdisciplinary team? Like you have several coordinators to deal with any one person?
So we have, how many would you say, Tanner? About 10, 15 service coordinators.
Per person or the agency?
So per agency, we have around 10 to 15, and then they, in turn, have several different clients that they work with individually. So it's service coordination slash case management. So they work with, they have their familiar service coordinator or case manager, if you will, and then that person, Tanner or I, can work directly with to say, okay, hey, do you know when their discharge from the hospital was, and if there's any special care that we need to follow up with, or where did this discharge note go from the hospital, and so that's sort of how we work with them. So.
Okay. Let's talk more about the independence of people within the agency or the people that you work with. So, let's go more into that.
Sure.
What type of independence do you really help them with? Like, let's dive in. Go ahead.
Yep. Do you want to take that one?
Sure. And I feel that's a very personalized question, and like it's different from person to person, and just we really have very person-centered goals for each person.
So what exactly is a person?
And so let's say
person-centered
I
goal.
just have a client coming to mind, like just being able to go out in the community and go shopping without being really anxious or overwhelmed with the situation, so that we can look at that and just see what steps need to be taken and have some measured progress.
So in other words, if they go to a mall, sometimes they might be overwhelmed with the amount of crowds.
Absolutely, and a lot of stuff that a lot of people that we work with have fairly significant behavioral issues as well, and so sometimes that is a big focus, just being able to be empowered to go out in the community, even though they're living in a moderately independent setting. They still might feel very restricted as far as what they are willing to do.
Like
personally.
for example, you might work with a client, and I've been overseas, that has a problem like getting into a closed space like an airplane. Like, how do you deal with, let's say, a 15-hour trip to Israel or a 12-hour trip to Israel? Of course you can walk around in the plane and do things, not stay, with the exception of them telling you that you have to fasten your seatbelt. But how would you deal, if I was a client of yours or someone in the agency that needed your help, how would you work with me? Let's say my wife and I, how would you work with us getting up to that point in terms of that example? Yeah,
so in terms of that example, we would work with the both of you together. We might have you come in to the office for a meeting and just discuss your what's going on and your discomfort with the flying, so to speak. We might recommend some, interventions maybe that you've tried in the past that have helped comfort you. We might also work with, if you have a psychiatrist or if you have a specialist or a provider that we can connect with and collaborate with, we might work with them as well. There might be some sort of a, depending on your belief system, there might be some sort of a herbal supplement or some sort of a psychiatric medication that you might be able to take to help comfort you on the plane flight.
But there are other alternatives to meds.
Oh, absolutely, absolutely. So
music or something.
Yeah, absolutely. So if you know, like I said in the beginning, if you have things that have worked and you've tried in the past that, maybe there is some soothing music or there's some aromatherapy.
Another example when you work with a client might be the person has to go take an MRI. That closed space, that machine, that would be, for me, that's difficult. So those are the things you probably would work on.
Absolutely, absolutely. And I've heard of people actually going in with earbuds and listening to some music prior to that particular procedure. And that was really comforting because they could listen to a song that was something that they'd always listened to that sort of calmed them down.
What other things do you work with the person? Other independent.
Yep. So we actually work directly with our shared living providers. So that way.
Explain what a shared living provider is.
Sure. So our shared living providers are individuals that are contracted through our agency who share their homes with our clients.
So it's not a group home setting?
It's not a group home setting whatsoever. All of the clients that are obtained services from Green Mountain Support Services have.
Does Vermont have group homes or mainly shared living providers?
It's shared living providers. We've pretty much since the closing of the training of the Brandon School, we've had the shared living provider dynamic, which is amazing.
Okay, so explain what that is.
Sure. So within the community, shared living providers who are just people like you and me, they basically get background checks through the agency, and they're contracted, if they pass, to go ahead and have a particular client, whether they be a traumatic brain injury, adult family care, or a person with developmental disabilities. They would go into their home and they would live there. So, and that's what they're called, as a shared living provider, because they're sharing their home.
Green Mountain Support Services would they go to the family's house to see if it's appropriate first?
They do. They actually do. They go on the service coordinators that would work with the particular client coming on. They would go in and they would check the home, and they would have our administrative staff go in and do a home inspection. So, and I'm not really sure as far as the home inspection process. Michelle could speak better to that, but they have to go through rigorous home inspection process. So they want to make sure the capacity's there, and if there's handicap accessible needs, that those are there in place.
Your take on more independence?
I just think it's really, it's a wonderful setting, having someone being able to open their home to someone, because I mean, not only does a client have a lot of support already just set up right when you get there, because it's a already set and functioning home, but they're also involved in everything that family is typically doing. And so I think everyone, client included, is really invested in just that family dynamic, and so they're involved in a lot of everything that they're doing.
What is family dynamics in terms of this case? Definition of.
My definition of family dynamics is just like everybody's problem is yours, and your problems is everybody's, and so everyone's there to support each other, and whether that is waking up, making sure everyone gets breakfast and is getting out the door to their appointments, or all that stuff, or dealing with the emotion that holidays will bring up. A lot of times, holidays can be really hard for people, especially if you're away from your family, and having that new network of support, and again, that other family dynamic is there to catch people when they need a little bit of a boost.
Okay, what are some misconceptions around the nursing field when you work with developmental disabilities that might not, based on the regular nursing field? Any?
Yeah, so We actually just had a nursing meeting not too long ago at GMSS where we were discussing how our particular field of nursing is a weird field of nursing. we all related it.
Why do you call it that? Go ahead.
We all just sort of called it a weird field of nursing because it's not your typical hospital nursing, and it's not the generalized home health nursing, and it's sort of, we don't really have sort of a label, so to speak. Whenever I put down, what type of nursing I do, I consider it more of a community health nursing because I wear many hats.
So you don't want to say on a resume developmental disability nurse?
Oh yes, I do. I do want to say that. I have that right on my resume. But we're sort of working as a team with all different clients, whether they be developmental disabilities, because Tanner and I cross-train. So we're working with developmental disabilities, we're working with traumatic brain injury patients and adult family care. So we consider ourselves in the community nurses with all of those populations.
How does that work? Since you said that you're working with traumatic brain injury, describe what a traumatic brain injury is and how does your nursing deal with that?
Basically, a traumatic brain injury is usually related to some type of trauma that
car accident,
either car accident or it could be otherwise. Sometimes there is an extended period where there's a lack of oxygen to the brain and certain parts of the brain are damaged. But it typically results in people having kind of a poor impulse control. One of the beautiful things I love about people with traumatic brain injuries is you never have to wonder what they're thinking about you because they will be more than happy to let you know whatever's on their mind. And it's really refreshing. I know a lot of people are kind of taken aback when they get very open, blunt and honest answers and questions. But it's wonderful encountering someone that doesn't have that filter necessarily in place, just because you don't have to guess, and it's a wonderful view into a very honest world, and so one that doesn't really stand on, I guess, societal norms, if that's...
okay, well, when we say that, since you say societal norms, what are some of the misconceptions around people with special needs when you first meet them? Because you're in the nursing field, so things, we are normal, okay?
Yeah.
We're considered normal and we should be part of society, but what are some norms in terms of...
Just from some of the feedback I've heard from out in the community, I think there's a lot of fear involved with community members because they just don't understand. So they fear the unknown and what they don't know about and what they're not educated about. We actually had a story where one of our staff members working out in the field was working with one of our clients, and one of our clients was sort of abrupt and was calling out really loudly in a store, and one of the shoppers in the store was actually pretty vocal about the fact that she was raising her voice in the store, and our staff member sort of said, well, you don't really understand, this person has a disability. So and was sort of like they were not as understanding and fearful because they didn't understand.
So because they didn't understand, what actually happened with that customer in the store? Did the customer say anything else?
I don't think they said anything else. I think that was the extent of the interaction, but I just think it's sort of the lack of the lack of exposure and the lack of, you know, because we have to remember that because in the past there was that sort of institutionalized feel, that individuals might not have been in the community as much, and now they are. So we just need to keep educating folks on, you know, on
Tanner, your take on that question? What are some misconceptions?
Yeah, and I think a lot of it comes back to like people don't typically have exposure to people that have different disabilities, and I think so often we're raised on this ideal of being polite and not pointing things out. And I mean, I remember when I was younger, I was told like it's not polite to stare, and so like I think out of this
or
point or even question or say why is this the case with this person. I think just out of our kind of ingrained and kind of built up desire not to feel uneasy or not to point out something that we feel is different, that the public in general tends to ignore a lot of people with disabilities just because we don't want to bridge that gap. We don't really feel comfortable growing in that moment because we're just busy like trying to look as normal as we can too. And so I think people are kind of trying to be polite to a fault, and it's just something that people need more exposure to. And once people start seeing, say, a person in a wheelchair or sitting in a wheelchair instead of seeing a wheelchair coming down the street and how they need to politely avoid the situation, interact with that person. Like,
are people sometimes afraid with interacting with people, or they just don't know?
I think it's more just the not knowing. I think it can be intimidating for a lot of people just because, I mean, I think a lot of people are really afraid of offending someone that has been living with a disability their whole life, and they forget that they've been dealing with this for a lot of times their whole life, and so they're aware.
Being a nurse, have you ever had to interact with the police or anyone else of authority? And if so, how does that deal within your field? Like, if it gets to a point where you have to involve with the police department, you know, medically, because I know the police now are trained or getting more training with the people with developmental disabilities. Can you explain a little bit more?
I personally haven't had to work with anyone from the law, any sort of law professional. I know that there have been service coordinators in the past that have had to work with persons from the law, police officers. I think there's a lot of explanation that goes along with that. It's really difficult because we have to get multiple individuals involved because, again, we can't violate that HIPAA. So we have to be really careful, and there's a whole team approach to that. So,
in terms of team approach, historically, how has that changed, and how is that getting better through the nursing field, working in teams? Yes, no?
And I feel, it's, at least speaking with our agencies, we do have a lot of people involved in one person's care. Like, we have the service coordinator, we have nursing, we have program managers and clinical directors that are all making sure everything's flowing the right way and that attention's being focused where it needs to be at.
And if it doesn't go the right way, then you go back to the drawing board.
Yeah, and but then we, one of our big roles is just coordinating with different providers, whether that be primary care providers or psychologists or psychiatrists or neurologists or whatever the situation is that is kind of blooming at the moment. That's what we get the support from whichever area really needs to come from, and make sure that those other providers are aware that there is a situation, because a lot of times they have hundreds of clients that they're working with as well. And so.
Healthcare and the budget, opinion question. How has that changed? Or because I know healthcare, a lot of things are being cut, and services for people with disabilities are being cut. How does that change within your field of developmental disabilities?
It makes it more challenging, to say the least.
I'm sorry if I'm asking the right question.
Yeah, absolutely. It definitely makes it more challenging. What I've seen most recently is a lot of cuts with home health services, which makes it...
And why is that?
Only because of the funding for home health has decreased substantially, which is very surprising because it seems like that's the way the future is looking, is to have more individuals in their home. There's a lot of, you know, dynamics with politics and the funding with our current government leadership that is trickling down and is affecting that particular...
So home health is a better way of looking at things rather than putting persons in nursing homes, correct?
Absolutely. So if we want to compare some of the institutions we had for individuals with intellectual disabilities, we can kind of in the same way compare that to nursing homes for the elderly, right?
Well, nursing homes at some point were taking or can take people that aren't older age. If you're
absolutely,
if you're going through some medical thing and you're 16, 17 years old, a nursing home might take you depending on a situation.
Could and also just, you know, I feel like back to the home health piece is that's really what Tanner and my job is, to make sure that those services are in place, and they're in place the way that they need to be and they should be for the type of care that's being provided in the home. We're also there at the agency to make sure things that don't get missed. We actually had a hospital that had forgot to write a discharge note, and home health services were not put in place order-wise, and they should have been. So we followed up with that, and the home health's in place now, the order's there, so we're good. And you know, we're really good at picking up on if something's missing, and we need to sort of put that puzzle piece in place.
Tanner, we only have a couple of minutes left, but do you have any other to add to that?
And I feel like anytime you're keeping someone out of a hospital setting is going to be beneficial for...
unless they need it.
Exactly. And I feel like a lot of the issue we're seeing, especially in this area of the country, is there's just a big lack of nurses available. And so I think their staffing is always going to be a big issue. And if people are continually going into the hospital for every little thing where it could have been managed at home, then we're just putting more stress on the system.
You mean
that's already
like
overloaded.
hypochondriac type of thing? Like, I need to go in the hospital, I need to go in the hospital. Because you're wasting cities' money.
Yeah,
when
and
you're
there's that,
constantly calling the ambulance.
Or even just having nurses available like myself and Christina, or just home health to do quick visits. I'm very concerned about this. I need a nurse to come and look at it. And we can give a quick assessment and give our assessment to their primary care provider so that they can either say, yeah, like we need you to go to a hospital, or no, I think you'll be okay. Let's give it a couple days, do this and that, and then we'll reevaluate then. So.
Okay, last thing before we address and phone number. What's the difference between level 1, level 2, and level 3 care? Or is there like ways of putting it, like a level 3 care facility, you know, because I know we want to keep the person in the home, but let's say they cannot be there. What are certain ways of looking at it?
Do you want to speak to that one?
I'm kind of hazy on it. So.
Yep. So we don't particularly work with levels of care. It's more of looking at the person as an individual and seeing what their strengths are and their weaknesses, and figuring out the big picture as far as what aspects of your health do we need to focus on? Do we need to get physical therapy involved? Do we need to get occupational therapy involved? Do we need to have you see a neurologist? Or how do we go about making your life better and easier and healthier?
In the home.
In the home,
Yeah.
absolutely.
Well,
I guess, our big role is, like, if someone is questioning whether they are in like an emergency situation or not, we're there to kind of take in what the situation is as they describe it, and then advise as far as
Well,
Can I just say one more thing too?
Yes, ma'am. Yeah.
I just want to say that I really enjoy working with all the populations that we serve, whether they be with intellectual disabilities, adult family care, or traumatic brain injury, and GMSS is an excellent place to work for. I'm actually a member through them of the Developmental Disabilities Nursing Association, which is a great resource, and I'm actually going to their conference this year, which I'm really excited about. So, sorry, just had to plug that.
Oh, you want to say anything else about Green Mountain Support Services?
It's a wonderful place to be. I came from a hospital setting. And
you didn't like that per se?
I really loved it, actually. The schedule is really hard. It's very easy to get tired and depleted and a little
because hospitals deal with 7 to 3, 3 to. I've worked in hospitals.
Yeah, I was doing the 3 12-hour shifts a week, and I really appreciated that schedule. My family did not, and so it was really trying on them, and trying to find a balance there was it was more than I could ask. But coming to Green Mountain Support Services has just been wonderful.
Better schedule.
They're so accommodating. They are, and I consider them my family, and I've been working with them for about 8 months.
Yeah.
On that note,
We're like a big family.
Yeah.
Yes. On that note, we'd like to thank you for joining me on this edition of Able Done on Air.
Thanks for having us.
For more information on Green Mountain Support Services, where can they go?
They can go to gmssi.org. And you can...
Is there a phone number?
Yes. 802-888-7602.
Repeat that one more time, please.
That's 802-888-7602.
This program is sponsored majority in part by Green Mountain Support Services and Washington County Mental Health. Able Done on Air is generously supported by Green Mountain Support Services to empower neighbors with disabilities to be home in the community. Other sponsorship include Washington County Mental Health, where hope and support come together.